All right, let's go ahead and get started. I want to be mindful of everybody's time. Good morning. My name is Daryl Gordon. I'm Vice President of Marketing at MediKeeper. So, if you've joined me on a call before in a webinar, I always start off by boasting how incredible the weather is here in San Diego. But today, it's kind of out of sorts because it's a miserable, freezing cold 54 degrees. So on the positive side, I can tell you that we've got a fantastic session planned for you today. And today's topic, practical solutions, we have Dr. Tyler Amell, who is the Chief Health and Strategy Officer at MediKeeper, presenting for us. Dr. Tyler is an internationally recognized thought leader on the topic of workplace health and productivity, and he serves on the Executive Board of Directors of the Work Wellness Institute and the National Wellness Institute. So because we have a large group today, what I'm going to ask is that you have any questions, if that you use the Q&A, the chat functionality, and we'll get to as many of the questions as we can. I apologize if we miss any. I promise we will follow up with you afterwards. So with that, Dr. Tyler, are you ready to dive in?
Sure am. Thank you very much, Daryl. Good morning, everyone. Thank you for taking time out of your busy schedule to join us here today. This is our second in a planned series of 3 webinars, which is new for MediKeeper. The first one was on lessons learned from the pandemic and how we've never had such a spotlight shown on employee health and productivity, and so that has been quite a boon in many perspectives to what we do from worker health protection perspective. This one is focused on work disability and work disability prevention, and how, if we take a step back and look at broader approaches to health and productivity, we can perhaps gain some efficiencies in how we address certain elements of programming. And stay tuned for the third session, which I believe is scheduled for May 12th, but we'll talk about that at the end. Here are some customary affiliations and disclosures. As Daryl mentioned, I'm the Chief Health and Strategy Officer at MediKeeper. I also hold an adjunct faculty position at Pacific Coast University for Workplace Health Sciences, where, ironically, we actually have a bachelor's program in disability management. So a lot of the learnings in some of my courses that I teach there are actually included in this particular deck. And as Daryl mentioned, I do sit on the board of the National Wellness Institute as well as the Work Wellness Institute, and look at things from very much an evidence-informed, data-driven perspective. There's my LinkedIn contact information if you want to reach out. It'd be great to hear from you. Now, whenever we look at the integration of various types of programming and support activities that are in place to help people out, we can look at it through several different lenses. So what you're looking at here is where various pieces of the puzzle fit together. From a health and productivity management perspective, of course, we have group benefit and group health plans in place. We have EAP solutions, so employee assistance programming or behavioral health approaches. These are slowly being looked at through the lens of life guides now, and the EAP world is changing rather dramatically because it's completely underutilized. And there's some good solutions there that perhaps with a refresher can be a little bit more meaningful to people's lives. Wellness programming, health management tools, disease management types of activities are all included in this broader basket. Then from an accommodation perspective, we know we have the ADA and ADAAA needs to be administered. And so having these types of program elements interlinked, if you will, or at least looked at through a strategic lens, helps improve our understanding of the current health of our workforce and the productivity side of it, and of course how you can control and prevent some of these exposures to reduce the likelihood of people moving into an episode of temporary work disability. From an absence management perspective, we obviously have sick time components for some employers. We have paid time off or PTO. We have leave of absences, and a particularly problematic sub area of intermittent casual absenteeism and leave of absences in there, which do require some rather sophisticated approaches to help manage the risk for both the worker and the employer. And then we get into the realm of integrated disability management. So this is the IDM space. So, here we're talking about short-term disability, long-term disability, workers' compensation, and then the FMLA, so Family Medical Leave Act, municipal, county, and state leaves. This is very much a rich tapestry, extremely complicated, particularly for multi-state employers to help wrap their heads around and manage their risk accordingly. Now, from a cost side, depending on the nature of the program or plans, your STD plan could be self-insured, it could be, ASO'd, administrative services only. There's lots of different ways to handle that. Long-term disability, though, based upon my conversations with employers over the past few years, I've met very few employers who did not see a double-digit increase in their experience rating on their LTD plans. So obviously there's a long runway to get to LTD. So if we're able to intervene in the STD phase or help mitigate risk or improve the health value proposition prior to people entering into a state of long-term disability, an employer and organization would be far better off investing in these types of activities and solutions, simply because the cost of those programs are rather significant. Now, one of the things that I like to do is look at things through a slightly more practical lens. Obviously that's the theme of this short session. We want practical solutions. But one of the things that I've come across on, day after day, year after year, is that there are so many different approaches that employers have to how they address health in the workplace. Some it's a priority, and in others it's somewhat less of a priority. There's some commonalities there. The focus tends to be on keeping people at work and productive. And we have strategic investments in health. We have environmental health and safety programs or occupational health and safety programs. We have primary, secondary, and tertiary initiatives. So primary prevention is removing risk factors. Secondary prevention is detecting asymptomatic people prior to something else occurring down the line. And tertiary prevention is very much the disability process and the accommodation process in place there. We have strategies to deploy risk reduction. We have health risk assessments, health risk appraisals. We have well-being programs, well-being investments. We have health surveillance activities. Lots of folks in HR are quite focused on engagement these days. So engagement being discretionary effort, particularly as we have a large portion of the workforce working remotely. So how do we ensure that people are engaged in the culture and engaged in their organization outside of the health space? I was given a talk in San Francisco a few years ago, and the topic of my presentation was health engagement and productivity, and how you actually can't have engagement in the traditional HR sense unless you have health. And so, linking it to productivity is very straightforward in that perspective. But half the people in the audience were traditional HR people who looked at the term engagement as being discretionary effort. The other half were health and well-being people who looked at engagement just through the lens of how many people are interested in programming and making a change with regards to their health risk and what they can do to help them achieve their best health. So it was quite interesting in that perspective, is that there's still a lot of misunderstanding in there around there. So I think we're getting better now when it comes to the term engagement and what HR is looking for and what the providers are looking to help support. Culture crucial, and then health, medical, and pharmacy benefits accordingly. Now, from a health-related perspective, there are instances of what we call presenteeism. So that's people who are engaged in the workplace, but not necessarily functioning at the best of their ability. And so the name of the game here is supporting people who perhaps, their mind is elsewhere, perhaps they're dealing with some chronic disease situations, relationship issues, financial problems, these sort of things that are impacting their health. Perhaps there's stress, perhaps there's anxiety, and they're not necessarily able to deliver to the best of their normal ability. So we have a term for that, and we call that presenteeism. There's some good estimates out there. With regards to the actual impact on the bottom line, you lost productivity associated with health while people are engaged. Now, the other area is absenteeism. So this is people who are disengaged from the workplace, usually on a temporary sense, either with an episode of temporary work disability or assigned to another means of absenteeism. And sometimes this is planned, planned absences, PTO, so paid time off, vacation. This is people withdrawing from the workplace for a certain period of time to help them recharge their batteries. And that's a very positive thing. There are casual or intermittent absence episodes. There is culpable or non-culpable nature in some of these as well, when people who are frequently absent, without any justifiable reasons in place. So from a health and productivity perspective, there's lots of things that we can do from a prevention perspective at the front end to reduce the likelihood of people entering into an absence episode. Now, when it comes to work disability, we've got various different schemes in place to support people in this sense. So I am not a big fan of occupational or non-occupational types of injuries. If you label something as non-occupational, well then, some people can make the assumption that it has nothing to do with the workplace, when that could not be further from the truth. The terms that I like to use are work-related for traditional occupational illnesses and injuries, or work-relevant. So you never lose that work component to it. So for non-occupationals, work relevance is a far more inclusive and a far better term when it comes to strategic management in this sense. Now, the name of the game here is moving beyond this concept of disability management into disability prevention. So, and we'll talk a little bit more as how that works. Our prevention efforts are focused on promoting healthy relationships between all stakeholders. Clear expectations around the absence episode, supportive return to work practices, and so on from many different perspectives. Now, traditionally, work-related insurance schemes were workers' comp providers, and work-relevant are sick time, LTD, STD, perhaps self-insured, perhaps fully ASO'd. Now, it really doesn't matter at the end of the day, from a productivity perspective, the underlying rationale or reason why somebody has entered into an absence episode. It doesn't matter at all. One could make a pretty strong case, and I've been doing this for years, that if it is a work-related condition covered under a workers' comp, then in theory, if this illness or injury resulted from employment, then you're in theory in control of the workplace. Thereby, there's things that you can do to drive down that risk profile. And so you're probably better off with workers' comp exposure because you do have more control over the very nature of the workplace, from a psychological health and safety perspective, from a physical perspective, musculoskeletal conditions, exposures to chemicals, and so on and so forth. Now, the work relevance side, employers have less say into what people do when they're not at work. And so this one becomes a little bit more jaded, if you will. We've got public health, of course, we're sitting in the middle of a pandemic right now. There's lots of good data around why we should be looking at protecting health from that sort of perspective. But traditionally, we haven't really done all that much from an injury prevention and control perspective with those elements from a workplace perspective. But some advanced employers out there are going to promote off-the-job safety or off-the-job health. And of course, well-being initiatives targeted at, let's say, chronic disease or other risk reduction strategies are tied back into that overarching philosophy. So, even though the insurance forms and the payer is a little bit different from a productivity perspective, it really doesn't matter. And so, these historical silos that have been in place, I did one work with one large employer, and, they had a completely different process and philosophy around their work related versus their work relevant. They have since changed that approach to bring them much more in line with helping people regardless of causation, because they're still focused on maintaining that productivity or improving that productivity gap. So whether it's return to work or work reintegration, the desired goal really is the exact same, regardless of the payer or the insurance plan in place. And so organizations who understand that and integrate that approach are far better off. Now, of course, we have a tremendous amount of capabilities on case management, recovery, and support. There's lots of different ways that organizations can deploy these types of solutions to help people who are in an absence episode and labeled as temporarily work disabled to return back into the workplace. Early intervention has a tremendous amount of research to support its use. Stay-at-work strategies are becoming far more important than they ever have. So looking at stay at work as a primary option rather than moving into an absence episode whereby you're going to have to shift focus to an eventual return to work is not as desirable, but in some cases it's the only way to handle it. A motor vehicle collision would be a prime example of something like that. Now, as I mentioned before, employee assistance or life guides programming underutilized, but definitely part of the equation. And one of the lenses that I like to look at employee health is through a continuum. So, we don't typically see people injured or ill joining the job in an injured or ill state. Usually you wait till people recover to a certain degree before bringing them on board. And then ideally, you want to keep as many people in a healthy state as possible. Now, as we age, our risk of disease goes up. We become weekend warriors from a sporting perspective. And, that softball tournament over the weekend could have repercussions when we come back to work on Monday. Whether or not that transitions into a short-term or long-term disability, injury, or illness is another situation altogether. But from a chronic disease perspective, we know that, as time progresses, the risk does go up. And if you make a lot of choices with regards to your own individual risk profile that aren't necessarily aligned with optimal health, well, then there are repercussions to that as time moves on. Now, from my perspective, I'm an epidemiologist by training, so occupational epidemiologist. So I specialize in population health and preventive medicine and working populations. So I sort of sit at the nexus between health, data, and technology, and how we understand the value proposition for our own investments in prevention and health and productivity solutions. So we know that integrating in all these solutions, we need to have good technology in place. We have to integrate process. We have to integrate data, integrate reporting. We have to be aligned with regards to supporting outcomes and very much supportive of data-driven decision making. So this is a schematic that I tend to refer back to a fair bit when working with employers on their overarching health and productivity strategy, because it does tie in, a rather rich tapestry, if you will, on all the different aspects of health that can be related to productivity, as well as to the very nature of work itself and how we help people move the needle in that respect. Now, from a practical solution perspective, early intervention works, and it works very well. I did some work with a carrier a few years ago, and for a certain subset of their mental health claims, they were hoping for self-resolution. That is not a good strategy by any means. There's things that we can do in an active sense. If the conversation changes from, we're sorry that you're hurt or injured or dealing with a health condition, let's figure out a way to work together because there's vested interest on behalf of everybody, all stakeholders. And so getting people to buy into the notion that they are responsible for a portion of their health. In fact, the largest single portion of health responsibility is actually on the behaviors that you have, the lifestyle choices that you make, far more so than genetics or epigenetics or even health system or health services availability. So, having that sort of philosophy and culture ingrained within the fact that, yes, our health is in our control to a certain degree. We can't control our age and we can't control our genetics, but, there's lots of other things in place that can help modify those outcomes. And one of the other strategies is to link your real-time absence surveillance to both your upstream and your downstream approaches. So you don't wait until someone is absent before you act on anything. There's lots of indicators prior of let's say casual or intermittent absence episodes that are related to future longer episodes of temporary work disability. And so given the cost associated with those, it's far easier to maintain connectivity and maintain contact with people while they're in the workplace before they disengage. And so if you've got better real-time access to absenteeism data, you can have that early intervention, that return to work or stay at work, best practice seed planted much earlier on. And so this definitely has very strong outcomes for a lot of organizations who are looking to tweak and improve their approach to work disability. Now, some colleagues of mine at the Integrated Benefits Institute a couple of years ago published a paper, and they actually looked at casual and intermittent episodic absences, or in this case, leaves, as a predictor for longer term leaves, in this case, FMLA leaves, and work disability. And what they found was that there was a clear relationship between these infrequent casual or intermittent episodes, over the span of, let's call it a year and a half, 2 years, leading up to a much longer duration. So there was lots of opportunities for early intervention, even before the traditional sense, because traditional sense means you intervene early as soon as somebody disengages and enters into an absence episode. And perhaps there's work disability with that. But the idea here is that you're swimming far more upstream and looking for these indicators on these integrated data sets and seeing, what could happen, and then offering up support to those individuals to increase that connectivity. Now, of course, this is absolutely crucial because work is good for us at the end of the day. And, when we look at, studies associated with mortality and morbidity and these sort of things over long periods of time, relationships are absolutely crucial. But connectivity, particularly to the workplace, and the workplace is a significant contributor to positive health. So maintaining that connectivity is crucial in so many respects. Now, from a prevention perspective, avoiding random acts of wellness is definitely a strategy. You never want to have, a flavor of the month sort of thing. Well, let's go out and buy gym memberships for everybody, without tied to an overarching health and productivity strategy. There's not a lot of research evidence to support those types of activities. But targeting, chronic and episodic health conditions can definitely pay off from a prevention perspective, and of course, driving down the risk profile from an episode of temporary work disability. Now, because chronic and episodic conditions, they don't typically develop overnight, you're not going to see solutions right away with regards to these. These are longer term investments. Julian Rafe's work from Chicago from a couple of years ago showed quite clearly that, you're not going to see a significant return until, 3 or 4 years down the line. But you can make pretty strong arguments for the fact that, making health improvement decisions to reduce your risk profile pay off dividends in so many ways. But from a work disability perspective, there's lots of things that can be done to reduce the bottlenecks and improve stay at work and return to work outcomes. You can look at efficiency of reporting. If there's a psychologist involved and they're taking 2 or 3 weeks to produce a report, well, that's not very beneficial to the injured worker or ill worker off, because there could be work loss, there could be wage loss, there could be lots of different factors contributing to cost, but also ill health, which is extremely important. Because we know that poorly designed work disability management approaches are iatrogenic in nature. So that essentially means that a poorly designed program and approach to workplace health actually contributes to ill health. If you're having to constantly prove you are injured or ill or disabled or temporarily work disabled, that reinforces the notion that, yes, in fact, this is true, rather than spinning it into a positive and saying, there are things that people can do, even if they are temporarily work disabled. And so, looking at things through that iatrogenic lens will show that, in fact, having poorly designed approaches contribute to longer disability durations and poorer outcomes. So quite problematic for us. And one of the ways that we can address that is by adopting worker-centered approaches. So some colleagues of mine on the East Coast a couple of years ago totally revamped their approach to health and productivity solutions. And how they did it is because traditionally organizations, particularly HR and occupational health and safety, they're set up based upon functional departments. So it makes sense to have, STD, workers' comp, occupational health and safety, wellness, nursing, hygiene, all these sorts of elements, from an overarching sense, all in these silos. Not really thinking about somebody moving through a health continuum and ticking off all the different elements as they move through the process. So what they did is they actually studied the workflow of an injured or ill worker as they tried to navigate through the system. What they found was that there was substantial room for improvement across the board. Now, from a fitness for duty perspective, one of the things that I like to do is traditionally fitness for duty is people under the influence of alcohol or drugs in the workplace. But we can look at that through a much broader lens. We can look at mental fitness, focusing in on resiliency, building up people's battery capacities. Physical fitness, of course, we've got a mountain of evidence to support these types of activities as well. So I view this as a very useful approach going forward. Now, the other thing I would mention is that for those organizations not familiar with more holistic or more modern strategic approaches to dealing with health and productivity, a total worker health approach is definitely recommended. This NIOSH actually has great programming in place and support, to help organizations understand the need for de-siloing and move towards a far more integrated and strategic approach to managing the risk profile. Coordination, communication, absolutely crucial. And again, I can't say this enough, integrating your prevention efforts with your health-related benefits for healthy, injured, ill workers, all completely recommended and are backed up by good quality research studies that show that this is the preferred and the most advantageous strategy to adhere to. I realize it's like drinking from a fire hose. You only have 25 minutes or so to get through this sort of content. I tried to keep it high level and strategic, but still provide some practical, meaningful, meaty solutions for folks to take forward. If you have any questions, now's the time to probably put them into the panel. I would like to mention that this is the second in a 3 series. So this is the first time we've done these moving forward. So it'd be great to get some feedback as to if you want to attend future ones, and also what topics would be of most interest to you. And also, if you do have some extra time in your schedule next week, I will be giving the keynote at a Blue Cross event, the Wellness Summit, next Wednesday, the 21st. So feel free to reach out to me on LinkedIn and definitely hook you up with the information on registration for that. The topic of that talk will be, what does the future look like for health and well-being investments moving forward out of the pandemic, and how can we catalyze on a lot of the energy that we're seeing in this particular space right now moving forward.
And Dr. Tyler, well, I see we've come up against our timing over here. So I'm going to take all the questions and we will respond to everybody personally. But thank you for your time, Dr. Tyler. You always provide us with such insightful information and some practical solutions. And so, yes, it was a lot of information. You gave me too a lot of homework here as well. But thank everyone for their time and for joining us. You can learn lots more about MediKeeper on our website, as well as a demo request if you'd like to learn more about our platform. This concludes today's session. Thank you so much for joining us. Have a great day.
Everyone, take care.